Well, welcome to the second part of this talk. We're still talking to Dr. Rebecca Hall and Dr. Mary Valentine, both experienced GPs. Dr. Valentine's also very experienced as a GP trainer. And as we've said, they've both really stepped up to the plate during this pandemic to make quite a significant difference. And this has basically been done via remote assessments. Now, I'm struggling here a bit, Becca. So start me off. What do you mean by remote assessments?
Remote assessments are where you're not in the same room as the patient, essentially. So you don't necessarily be that remote, but you will be communicating not by being in the same room, but by being face to face. So we tend to distinguish between face to face consulting and remote consulting now. We've been doing this for a long time. But the proportion of how much we're doing it really changed in the pandemic. And this system that Marion, the one-on-one service that Mary and I have been part of, has been purely remote assessment. And then we've triaged, as we said in the other video, about whether people actually need to see faces. Remote assessment was seen as an absolutely essential thing when the pandemic hit, that in order to keep people safe, to keep people away from waiting together in doctors' surgeries, to keep the doctors safe, because at that point there was no protection for doctors and nurses. And we, this was established as the way forward. And some of us had done a little bit of it before, some of us had done it a lot before, some people hadn't done it at all. And so not only were they dealing with a new condition, a new disease, but also a completely new way of assessing, which is quite challenging, has its own challenges, and is quite different from the way that we've practiced medicine in the past.
And what technologies are involved in this?
Chatting on the phone.
Right, so do you do video calls or just via voice calls?
Yeah, we can do video calls. I mean, various technologies sort of became, were introduced during the pandemic. There's no universal system. So if you work in one GP surgery, they'll have one system, and if you work in the one-on-one service, they have a different system. And I think it was about sometime last summer they introduced video calls for our one-on-one service. Sometimes compatible with your phone, and sometimes they're not. And the same. So we use video calls. We use phone calls. We use text messaging, and of course e-consult is something that not everybody uses. So different people do it in different settings, use a mixture of different ways of assessing remotely.
What is e-consult?
I think it might be a brand, but it's about people, doing it on. It's online consulting, and often it may well result in a phone call, because often you're triaging in one setting and you think, actually this is going to be easier if we do a phone call, or you're doing a phone call and you think, actually this is going to be easier if we can convert to a video consult. So you might just do a video consult as a couple of minutes in the middle of a phone call. That's quite common, actually. We all got quite excited about video calls initially, but I think there is a place for them, certainly, and sometimes it's interesting, the patients like them. Sometimes I would choose to do a video consult, really to help to establish a better rapport, so that the patient felt they could trust me. Certainly mental health, people with mental health problems, it can be really helpful for building up trust. There's all kinds of different reasons we might use them.
Do you find you can build up trust, Becca, on a remote assessment?
Well, it's something we've worked on. I think from the moment you're speaking to the person, at that point you've got to think, I've got to establish a really good relationship with this person. And for me, I do that we all have our own ways of doing that. I use real informality, and so even when I'm introducing myself, I say, my name is Rebecca Hall, I'm a GP. My name is Dr. Hall, because I think I just think it's different, and I want them to feel as relaxed as possible. And then I explain things. But all that time, I'm also listening to them, because as soon as they pick up the phone, you're assessing them, assessing who they are at that moment in time. So you're not just gathering information about how they're saying it, especially because when people answer the phone, sometimes they've gone to another room to answer the phone, and you can, they can actually be quite, breathless at the point where they answer the phone. and that will completely change how you consult with that person. You might actually get very far into the consultation because you're thinking, because you say, look, I just noticed that you sound really quite breathless. Tell me a bit more about that. You know, straight away, and I've got the topic there.
So you're picking up things from what the patient says and just your general observations of the patient, even if that's only on sound, you can tell quite a lot from that.
Yeah.
Yeah. No, that's good. Mary,
it is challenging though, because
oh, go ahead. Yeah. Sorry, Becca, go on.
Well, Mary's got a lot of experience. Mary's got a lot of experience actually with training people, and I think she can talk about, because there's an awful lot that you do miss on a telephone call.
Sure. Yeah. Mary, do you want to talk us through a consultation? Someone calls you, and what's the sort of what do you run through?
Well, the first thing is to make sure that it really who the person is at the other end of the line. So, you know, you're normally, if we're looking at the COVID 111 service, we don't know these people. So when I'm thinking about my practice, I'll see the name, I'll phone them up, I recognize their voice. You know, so they recognize my voice, I recognize theirs. This is a completely different setup. We're complete strangers to each other. And we have to be very mindful that there can be two John Smiths in the same house. And they may, so you need to check that it's not just John Smith, but it's also the right John Smith with the right date of birth. And we want to know where they are. So if we're looking at an emergency service like the one we're dealing with, we want to know where they are. Are they there at the moment, rather than just the address that they're registered at? We do get people that collapse their nurse, and it's, yes, we can mobilize an ambulance, but if we haven't checked their address and they're at that address at the beginning of the call, then the ambulance might go to completely the wrong place. So it's the real first things are the demographics and introducing ourselves so that we know who each other are. And then when we're going through the consultation, generally you're starting off by saying, what's made you call us today? What's made you get in contact with us today? Because you want to find out from them first off what their concern is. And within the COVID service, it might be that they were just going online to get a test. And because they answered certain questions, it's come our way. Or it might be that they're desperately worried that somebody with or themselves might need to go into hospital because they're really, really unwell. So you want to get that bit of information out there first and make sure that you're not dealing with an emergency situation. And then when you're then going forwards, you're then trying to find out exactly what the problem is that they're concerned about to start off with, but then start to collect more background information. And I don't know whether you want to talk about that in context of the COVID line or just more.
Yeah, I would have thought so. Yeah, and chip in, Becca, as well, when you've got something to add on this.
Okay, so when we're starting off, it's how are they, what are their symptoms, and then going through and trying to assess what those symptoms are like, but then saying what other bits of information are important for us to know. Yeah. So who has this person actually been in contact with anybody that they know has had COVID? Have they been going out to a situation where they might be at higher risk of getting it? And obviously cases are low now, but they have been very high in the past. And it's who else is in that household. So of the people in the household, are any of those particularly vulnerable? Do we need to be protecting somebody in the house from them? Or are they going to work? Might they be infecting other people? Are they going to school? And how many other people are affected by it? And in the second wave, we were finding far more people in the household affected. When the new variant came, whereas it might be that one or two people in a house might get it, or one person might get it, but nobody else in the house did. It was really common to find everybody was down sick. That was quite common. So it's like, who else is affected? Because you're not necessarily just dealing with the one person. You may be dealing with somebody else in the household. So the person you're talking to might not be the sickest one. So it's being mindful of that. And then you're looking at, okay, so if this person might have COVID, then what are their particular risk factors that might put them at higher risk than somebody else? So you're looking at wanting to know about their past medical history, what medication they might be on, their ethnicity, are they overweight or not? Do they have other disadvantages? Are they, maybe got learning difficulties, maybe they've got dementia, maybe they don't hear particularly well, and that's a real challenge with telephone consulting. And that can be a time when the video consults are better, because the person might be able to lip read you, and that might help their hearing. One thing I didn't mention to start off with is it actually the person you're talking to? Because quite often our calls are made by third parties, and if it's a third party member that calls, you need to be sure that you actually get to speak to the patient, because that's where you pick up things like Becca was saying, like actually they're breathless when they come on the phone, and that you cut to the quick, and we need to be dealing with this in a more urgent manner. So you need to be sure it is the patient. And if quite often you'll find people say, oh, no, they want me to take the call for you. So we have to be quite insistent and say, we just want to make sure that we can speak to them and that they give me permission to talk to you. And obviously we have a lot of people who don't necessarily have English as their first language. So we might have to get a translating system involved, and we can do that through a conference call. So there are lots of different challenges along those ways. So it's one of the big things that you find when you're talking is that we will be talking and listening and typing, and you have to, whereas you're face to face, the person knows that you're listening and that you're still there. On the end of the phone, it might just go quiet. And so they think that they've been cut off. So you do have to do quite a lot of and yes, okay, and repeating back to them, and we call it active listening, where you're just like the person knows you're there. And if you're doing something else, like I just need to write this down, you have to say that that's what you're doing, because otherwise they kind of get confused by the silence.
So does the information you're gleaning from this consultation, and by the way, I thought that was an incredibly logical, progressive way to structure the interview. But does this go on to their NHS records, their own GP records, so that their own GP can see that this consultation has taken place?
Yes, it does. So when we first started, we didn't have this set up that we could access the GP records. We can now. With permission from the patient, we can actually access their summary, which is really helpful. But when the consultation is finished, it will go through to the GP practice. But if we're sending them somewhere else, like an out-of-hours service or a hot hub, when we had hot hubs, then it would also go through electronically to them. So to whoever was on the receiving end of that call, if they were going elsewhere, they would get an electronic copy of it, and it would go through really quickly. It wasn't so set up for things like hospitals, unfortunately, but certainly for any primary care outcomes, it would go through to them.
Right. So this is joined up with other healthcare professionals. I think that's a really, really important point. But Becca, does this relate, when you're listening to this, Becca, does this relate to a normal GP consultation? Are these the sort of steps you would go through normally in your day-to-day work?
It's not quite the same, no, because you have to work when you're speaking to someone. You're very aware of how they came to you, and so often, in a GP consultation, you'll be aware that they made the appointment that morning, or they made the appointment 2 weeks ago. Whereas with these one-on-one calls that they've made the appointment, within the last hour, and they've been put in a queue, and our queue is divided according to the severity of symptoms. So we know that if we pick up from the red queue, they've been triaged so that they need to speak to a doctor within an hour. And so how you structure your call is going to depend on how somebody has arrived at your care, really. And certainly, and as Mary said, you know people in general practice, and there's a different expectation from them, and so it just has got slightly different angle to the call, really. There's less checking of, well, you do check who people are actually in general practice, and certainly doing the one-on-one work has informed my general practice work much in quite interesting ways, and I'm very much more careful about talking to third parties now. Getting a history from somebody else who isn't the patient is something I'm very wary of, and that does happen in general practice, that you hear from a concerned relative and they're in a different house, and it's quite. And we used to accept that as a sort of a way of hearing a history, but actually now I think I really need to speak to someone who's with the patient, and so it's we're all learning all the time about how to do these calls most effectively, to be able to do the best assessment for patients, so we get them to the right place at the right time.
Mary, we talked about a red call there. How are these calls prioritized? So some people have to talk to you within an hour, some people have to talk to you within particular time periods. How does that work?
Yeah. So when people go online, it depends how they've answered the questions. So they can go online or they can speak to a call handler, and depending on how they've answered them, they will be put in certain categories. So if someone, for example, had been getting increasingly breathless over the last hour, that would be the highest category. That would be Or whereas if somebody had symptoms that hadn't changed over a few days and their symptoms seem to be a lot more minor, it might be within 12 hours or within 24 hours. But the majority of them would come through as 1 hour, 2 hours, 4 hours, or 6 hours.
Right. Okay. So, Becca,
that's algorithm led.
Yes. Oh, sorry. Yeah.
Service. And one of the things that it's really obvious to us when we go through is that we would probably have a look down through the list of the 6-hour calls for people in their 80s, because people in their 80s downplay their symptoms, and people who are a lot younger have a lot less tolerance of their symptoms. So you might well find younger, fitter people giving answers that put them in a 1-hour category, and much more unwell people in older age groups who would be in a longer time frame. So it was something.
So the British understatement in the elderly.
Yeah, absolutely.
Interesting. That's
it's not perfect. The algorithm isn't perfect, and we do find, as we know, we end up calling ambulances when we pick someone from the 12-hour queue. All of these things are ongoing sort of projects to improve the way that we can do that kind of assessment, I guess. Yeah. Or the way that computers.
So you mentioned algorithms there, Becca. Are algorithms becoming more of a thing in medicine these days?
Things like e-consult algorithms, aren't they?
Yeah, they are, and even in a lot of our guidelines, we follow an algorithmic approach. We know is the patient over 40? Yes. Is the patient over 50? Okay, yes. And if have they got bleeding, then yes. Okay, so that to decide on what the management is. But essentially, they're using these algorithms to decrease the manpower needed to get to the point where the algorithm can no longer do any more, and they need to speak to a person. So we don't have an awful lot to do with this one. We're just on the end of it once they've been subject to the algorithm, I guess. Yeah.
Did you see a future, Mary, where we have a much more digitalized, de-doctorized diagnostic capacity?
Becca mentioned eConsult, and there are others like that out there. The clinicians on the receiving end often feel that what they've done is to make everything that much more prioritized. So somebody who actually, when you're talking to them, you're thinking, that that sounds as though they're fine. They might say something that the algorithm strikes out, you need to see a doctor within the next 2 hours. And actually it's something really quite minor. They can work really well from the point of view of if they're trying to direct you towards some sort of advice or whatever. But they are so, I'm not dissing them completely, because I think, you know, with the health service resources that we have, we need to use them in a way that's going to be safe and constructive. And there are lots of people that would phone up the doctor in the old days to say they've got a cold and, you know, get some advice for the cold. We can't do that, you know. No. And now we get COVID, so everybody's got to ring up because they've got a cold.
It sounds like you're saying algorithm medicine is not quite there yet, and it needs the human.
Yeah, and it's not there yet, and it's also not there yet because people answer in different ways. So like our 80-year-olds and our 18-year-olds, they get the same questions, but the way that they will answer them with the same symptoms will be very different.
Interesting. Yeah, because I know the Zoe app's working on this, isn't it? That you have a particular range of symptoms, and it's able to give a probability of a particular diagnosis based on a large data set of symptom reporting.
The other thing, though, John, is that it doesn't cater to patient expectations. Patients generally like to speak to somebody, and they actually like to speak to a doctor. And however brilliant the nurse practitioner they speak to, they still, a lot of people still perceive that they've spoken to a nurse. Now they want to speak to a doctor.
Yes.
So there's a lot of education needed for them to accept a machine. And maybe they will, but at the moment, you know, they still haven't caught up with where medicine's really got to yet, I don't think, in expectations.
No, well, we believe in the healer, don't we? You are the healer. I go to you. It's sort of a cultural belief, isn't it, really? And
whatever your advice you're giving to somebody, if you give it in one way, it can be negative. If you give it in a different way, it's positive. You know, it's a nocebo effect as well, isn't it? So if you give all these caveats and say this might happen, that might happen, well, you're not going to have much faith in whatever potion you've been given. So it can be difficult from that point of view. But I think the other thing about remote consulting is that it can be fantastic. But one of the things that happens when you're consulting remotely is you tend to talk about the one thing that person has phoned up for, because that's why they phoned. But actually, if you're seeing somebody normally, they walk down the corridor and you find, well, they don't normally walk down like that. What's happened to them? Or you see them and you think, gosh, they've lost a lot of weight, or they look a bit grey, or they look worried, you know, and you're missing out on all those other things that the person with who's talking about the sore throat actually looks as though they've got cancer, and that's nothing to do with their throat, or they look as though they're really depressed, and that's nothing to do with their throat, you know. So you're kind of missing out on all the visual clues and the body language cues that you normally get in a consultation.
So what you're saying there, Mary, is that as an experienced doctor, you can look at someone's face and think, oh, they look like they might have a malignant process going on somewhere. Is that?
Well, it's more that somebody just looks ill, and it may not be a malignant process. It might be all sorts of other things. Yeah. But they look ill, and they might go down an algorithm, or you might be talking to them on the phone, and you're not going to see that bit. And
therefore they wouldn't get the further investigations that you would do as a result of your suspicions.
So telephone consulting, fantastic. I've done it for well over a decade. So you come to see me, John. We decide that you need to go on some pills for your blood pressure. And so we start you on your pills for your blood pressure. You're doing some home BP readings for me. We're talking 3 or 4 weeks time. Make sure you haven't got any side effects. See what the blood pressure's doing. Do we need to up it a bit? Do we need to sort of reduce it a bit? Have you got any side effects? Do we need to change it? You don't have to leave home. You don't have to leave work. it's more convenient for you, it's more convenient for me, but I'll just be dealing with that bit. You know, so and if there is something else, is that a little bit harder for you to bring it up maybe on a phone when you're talking about problem A than it might be? Whereas if you're in front of me and I'm seeing you, I can see that there's still something you want to say that you're not saying yet. So
I'm actually really, I'm complaining about my bad back, but what I actually want to tell you is I feel anxious, or I feel depressed, or I've got a...
Oh, you might be complaining about your bad back, and actually your dad had prostate cancer and that's how it presented. Yeah.
Now, the thing that interests me here is I think you're seeing, well, you told me roughly with the remote practice, how many more patients in a day can consult you than you would see normally going through your own surgery?
No more. On the whole, a telephone, if it's a matter of, as I was saying, oh yeah, we're just checking your blood pressure, face to face, that, oh brilliant, that's a dead quick consult, but you're having the same sort of consultation on the telephone. If you're dealing with a telephone consultation, it is still a consultation.
Right.
And in my practice, we used to allow the same amount of time as we did for face to face. They're harder because you have to ask questions to get information you can see visually, and you have to safety net more. So they're not, it's not that they're quicker. And when we first brought it in, it was like, we'll do triage and everybody, and it works fantastically. Everybody was really happy. That much more accessible, demand doubles.
Yeah, of course, yeah.
You know, and also you get the same thing that Rebecca was saying earlier on, is that the person wants to see the doctor, so they'll do the phone calls, but actually what they don't count that as a consultation.
Yeah. But it is actually a full medical consultation.
Might do it more times just to get through to a face-to-face.
Yeah. But I mean, I would find that reassuring as a patient that I am getting the same. I'm getting 15 minutes or whatever it is of your undivided medical attention to think about my problem. I would find that really quite reassuring, actually.
I think the practice is that then it's not quite seen as the same as an ordinary appointment, so people are more likely to add them on.
Yeah. But Becca,
I think,
do you think
the difference is...
Go ahead.
No, it's fine, go on.
I was going to say, do you think there's more scope for people having basic diagnostic equipment at home? So that's my thermometer. This is my saturation probe. I've got an old-fashioned blood pressure machine, but why not have? Why doesn't every household have a medical bag to provide you with precise information?
If they speak to me, John, anybody who speaks to me, they get strict instructions that if they've got anything to do with their blood pressure, they should get a blood pressure machine, and because it makes their life much easier, and it makes our assessments of them much more accurate. So I think a blood pressure machine is particularly useful. Personally, I'm not so sure of the value of a thermometer, because I'm a great believer in the back of the hand, because if you've got a fever that you can't feel with the back of the hand, somebody else's hand, then actually it's probably not that relevant. And all this very exact temperature measurement, I'm not sure that it really has more value than the perception of having a chill, feeling hot, or feeling burning up, as a lot of people describe it. So thermometers, I feel, slightly less useful than other things, and that might be a bit controversial. I do feel a blood pressure machine is useful. It gives you the pulse and the blood pressure, and obviously with COVID, a saturation monitor has been exceptionally useful, and often the thing that we are referring people onto if they haven't got one at home. I know we shouldn't always be just treating people by numbers, but sometimes they can be really quite hypoxic and in need of oxygen, and it's the only way of telling, because they don't seem it, and that means they would make the difference of whether they need to go into hospital or not. So it's been a very, very useful thing, and it also tells you the pulse. But it also has a value in that it can be quite reassuring for people, and for them to know what their pulse or oxygen saturation is can be really, really helpful for people who are very anxious about their health, and that you can use it in a very positive way as biofeedback, so that can it can be a very, very positive thing to have. So yeah, hopefully more people will be getting them. A lot of people have smartwatches, and that can be very useful. But and some people used smartwatches during the pandemic for oxygen reading, but we don't really know that they're very useful. But I think we think that
they're perceived to be unreliable, aren't they?
Yeah. So, but heart rate monitors has been really helpful, and I've spent a lot of time teaching people how to take their own pulse, which is surprisingly not something that many people can do. But a few more can do it now because we've all been training them up.
Yeah,
I think I'm probably a little bit more old-fashioned than you, Becca, and that I actually find the thermometer really helpful. Lots of people say, "Oh, I'm feeling really, really hot," and I know myself, really, really hot, and I do my temperature at 37. And actually, if it was 39 or 40, that's really quite a big difference. So I think it's important not to get het up on a little bit here or a little bit there, but it can be a bit of a red flag if your temperature is really, really high. And
I do agree.
Yeah. So I'm quite a keen person on thermometers. The trouble is, the old days when you had mercury ones, John, they lasted forever. And now
I've still got one.
Now you get ones with batteries in them, and the batteries go flat. So there they are. They're at home with their COVID, and the batteries are flat.
This thing eats batteries. It's terrible.
So the other thing I think is really useful if you've got asthma is the peak flow meter.
Yeah,
absolutely.
If you've got diabetes and you're on treatment, which might make your sugars go particularly low, or if you're just being able to check what your blood sugar is pretty helpful too.
And then that gives you precise numbers to help your decision making as well, which is
does this
good.
person need to go somewhere and see somebody just to get that measurement done?
Yeah. So I think
it's really
go on, Becca. Sorry.
I think it's really good for patients. I think that it really empowers people to be able to monitor themselves, and we can enable patients to monitor themselves. In the context of COVID, there was a fantastic leaflet and scheme associated with the pulse oximetry and with the oxygen probes, which was really empowering, so that people would know exactly what the concerning red flag numbers were, as well as symptoms, and that they would be quite reassured by the ability to be able to monitor themselves. I think that really helped them, reassure them when they were staying at home with their symptoms.
I think this is what Mary mentioned about the placebo effect and nocebo effect, that, what you believe about your condition is really important to your condition.
Yeah, certainly the way we talk to patients is very important as well, and how we frame our advice and how we frame the explanation of their illness, and the words that we choose. It can have a massive effect on how they perceive, when I'm speaking to patients with anxiety, depression, I will often say, when you get better from this, and then I will talk, because actually that has an implication that they are going to get better from this without saying it, and that we know that helps them in their journey of illness.
Yeah, absolutely.
Is the NHS going to become progressively more digitalised in the next 10 years, Becca?
I'm sure it will. There's loads of tech companies already doing this, aren't there? And as we become more privatised, they will all be bidding to do our work for us. And also, there's a huge efflux from the NHS, and I think that there will be a greater, lots of people leaving the NHS, having had quite a challenging time during COVID. And so I think that a lot of the solutions to that challenge will be digital. Certainly a lot of the private providers are already doing it more than the NHS. It's, the NHS is such a massive organisation. Getting everything to link together digitally is really, really challenging. And it takes longer because of the huge numbers of systems and hugeness of the systems for it to actually work. So that's why I think that the smaller providers can be ahead of the game, really.
You've given some examples of when it does work, it's remarkably useful, like the way you can link with other primary care providers is incredibly useful.
And we can access results from our patients at their hospital, and patients can access their own records.
No, we can prescribe and send it to any pharmacy in the country, and that's brilliant. Possibly any pharmacy in the world if the legal side was sorted out.
Indeed. So you can prescribe any drug that you would normally prescribe over these over these 111 consultations.
Yes, we're encouraged to limit it to things that they need acutely, but often that can be things that they've run out of that actually think this person does need this. The easiest thing to do is just to prescribe it. So yes, we can do that, and then we just choose a pharmacy. You know, they've got some quite good postcode recognition software so that it tells you which the nearest pharmacy is to them. It's great.
When they're open. When they're open. John, we can't send it to a pharmacy in Wales or Scotland. It's only England, and I suspect that the Scottish and Welsh and Northern Irish equivalents have the same issue, that they can do it within their patch but not beyond.
But that could be fixed. I mean, that's an electronic fix to do that, isn't it? Presumably.
No further than Carlisle, John. You're the limit.
Well, we're about as far north as you get, aren't we? I mean, it's very reassuring that I know that if I was talking to one of you two people, you could prescribe for me. So that's nice. That's nice to know. I think last question is, this has got international implications, hasn't it, potentially? You know, we think about this terrible pandemic that's raging in India at the moment, and the distressing pictures. I know the technology is not there yet, but in theory, it means doctors from any part of the world could help patients in any other part of the world in the future, potentially.
There are people doing that already. There are small organisations doing remote support for other healthcare professionals remotely. And I think, I mean, it's quite complex doing it for patients from another country because of the legal and governance implications. And it's also not knowing there's setups there. So, for example, you know, our heart is going out to our colleagues in India at the moment who are having a really terrible time. And one of the things we have within our system here is we have something we call it the DOS, which will say, so you're in Carlisle and I need to see you, get you seen, and it will tell me exactly where the local ED is and when the general practices are and all this sort of thing. But we don't have the knowledge of other healthcare systems to be able to do that in the same way. And the advantage that is one of the advantages of having a unified NHS, because everything that we're referring to is part of a bigger organisation. And I think in many countries the health system is more fragmented, but the lack of current fragmentation in the NHS has actually allowed us to run this centralised system, which I think is unique. In that we don't know of anywhere else that's doing it on quite the scale, do we, Mary?
No.
Will there be a formalised academic assessment of the efficacy and validity of this remote scheme that you've been so dedicated to for the past year or so?
I know that within our setup, some people are thinking of writing things up about different aspects of the service. And I'm pretty sure that the organisation itself will be writing some reports as to how things, you know, there are all sorts of things in the background. For example, like, how do you get people to have laptops with the right stuff on it at home that they can use? And, you know, and how do we get all these people with their DBS checks done in a very short time frame? There are all sorts of logistical things, which must have been an incredible project to actually get going. I remember on the receiving end, to start off with, we was like, this onboarding is taking forever, but they ended up with 1,700 doctors within the system that had all gone
right. So I was just going to ask that, 1,700 doctors in this system. That is quite impressive.
And most of them would not have been working otherwise. There were people who'd come back from retirement. There were people who were shielding, and there were people a lot of locum GPs lost all their work in March, April last year because they just went down to skeleton staff in general practice. So it was doctors that wouldn't have otherwise worked, which is a really fantastic use of resources, really.
Oh, absolutely. I think it's brilliant. I'm well impressed.
But actually, when we talk to people, there are people that would not have come back into medicine who can now see a route back into medicine, which is good as well.
Excellent. Yeah. Anything else either of you would like to add? I think I've asked everything I wanted to ask, but any final points, or are you happy with that?
I'm just so glad those cases are coming down here, and let's cross fingers.
Yeah, absolutely. Yeah.
Don't take our eyes off the ball. We've got to.
There's a bit to go yet. Yeah. Well, Dr. Rebecca Hall, Dr. Mary. No, but Becca. Before I wrap up, speak.
John, I just wanted to thank you, because actually via people like me, I mean, there'll be a lot of us who've got a lot of information from you, which we've shared with our patients. So thank you for your commitment and regular updates, because that's been fantastic for me. A really, really easy way to get the information without reading through lots of papers.
Thanks, Becca, and you've just added lots of extra information in this talk. So thanks. So that was Dr. Rebecca Hall and Dr. Mary Valentine. I think we can say medical pioneers, and I'm sure lots of people will be very interested in this. And if you stay till the end of the talk, thank you for staying.
Well done. Cheers.
Good job.
Thanks, John. Well done.
That's us. We're done.